what we plan to do in this session is myself and my colleague Nick Hex, who's sitting on my right, will present for approximately 30 minutes, and then we hope to leave sufficient time at the end for a number of questions on the issues that we raise and picking up any points from earlier sessions this morning, because I think there are starting to be some common themes emerging here. What we are tasked to talk about is the QIP program in a little bit more detail. You could say it's sort of the microeconomics to follow on David Flores' macroeconomics from earlier on. And what we're basing this on is the general view that has been expressed by all sorts of people, both inside and outside the service. And we could have a little competition here to see who can guess who said which of these quotes. Just to give it away, that this one is Jim Easton, who is in charge of the QIP program. This one is David Nicholson saying the 15 to 20 billion. That's where that one first started off. And the bottom one is our great leader, Andrew Lansley, who is saying achieving this ambition will be extremely challenging, but it is essential. And I'm sure we've picked up that message from the speakers already this morning. So, just to remind people what QIP is supposed to stand for. Most people put prevention at the bottom, but I noticed Nick's been very charitable here and raised it one point up on the agenda, although many people worry that it's likely to be missed off at the bottom. So, the story, I think, begins with NHS productivity. And if you look at the green line here, that is the growth of real expenditure in the period from 99 through to 2008-09. And you can see that the expenditure line has risen much faster than any of these lines which actually measure activity. And a simplistic interpretation of that would say that clearly productivity has not increased while the resources have been pumped into the NHS, particularly in the last 5 years. Our colleagues at the University of York in the Centre for Health Economics have done quite a bit of research for the Department of Health around this area. And I think one of the big problems with this sort of analysis is the difficulty of putting in the improvement in the quality of services that has undoubtedly taken place during this period. They have done some estimations which take account, for example, of reduced waiting times as a proxy for quality, and that immediately closes the gap between the output and the finance lines. So you could say at that point that productivity has at least been held up during that period of increased resource. It hasn't leapt ahead. But if you start to factor the benefits that patients have enjoyed from improved services, then it doesn't look as starkly inefficient as has been presented in certain quarters. Now, a more recent study by the same team at the University of York looked at the relative productivity in the different SHA areas. And I think this was in the media a couple of weeks ago. And you will see here that this is just the English average is 0, and that's the difference in terms of improved. Battery's gone flat. The two to look at are the Southwest, which is third from the right as you look at it, and East Midlands, which is at the far left. And again, a simplistic interpretation is to say, well, if Southwest can achieve productivity targets which are up to 6% ahead of the national average, and East Midlands is 6% behind, clearly there would seem to be opportunities for some catch-up here and some easy wins. And the estimate they produced was just by evening up performance on this basis would save 3.2 billion or so per year. And that's just on a very crude comparison of that nature. So, although the productivity story may not be as disastrous as some figures seem to indicate, when you look at the relativities, there's clearly a lot of scope for things to be done better. I think we're all familiar with the McKinsey report, which mirrored the figures that the NHS board have been talking about recently, and they came out with the same ballpark figures of potential efficiencies that they identified, but they did suggest that at least 20 billion of savings was necessary to balance the books over the next 5 years, whereas the 15 to 20 billion was slightly more optimistic from David Nicholson. The King's Fund have also been working in this area, and John Appleby has produced 1 or 2 reports on this, and they identified a potential 21 billion shortfall, and the breakout of the diagram on the right of the slide there shows where this was going to come from. So the things that would have to be corrected in order to prevent that shortfall are things like looking at the capital program. Do we really need that investment? Pay and prices, do they really need to increase at that rate? Should demand be allowed to expand uncontrolled in certain areas as it has been, and so on. So at that level, the macro agenda is agreed by everybody. In order to meet the targets and the so-called protected funding target, 15 to 20 billion pounds needs to come out of the service without damaging quality. And I think that is the key phrase in all this. And what makes it doubly difficult, we all know ways of taking money out of the system, but can we do it whilst improving the patient experience and the quality of outcomes? The department has already identified 11 billion of the potential 15 to 20 billion and grouped under these headings on the slide here. So that was their first take on this, and there's clearly a long way to go on that. And inherent in these figures are some quite startling assumptions. For example, that acute providers would have to reduce their prices in real terms by 20% to meet the best practice tariffs, which will be pushed down gradually over the 5-year period, just to balance their books on current output levels. But also to achieve that, they'd also have to cut activity, i.e. activity would need to be transferred elsewhere or prevented altogether. So that's where the prevention bit of the QIP agenda starts to become particularly significant. If GPs are controlling 80% of the budget, then they're going to be front and center for facilitating the ability of people to take care out of the hospital into the community, but also equally facilitating the public health agenda, which we await with bated breath in the public health white paper to see some more detail about that. So, and this is the macro picture that our work is based on, and I'm now going to hand over to Nick, who will go into a little bit more detail on the work streams that the Department of Health have identified themselves, and to start talking about, okay, there are lots of good ideas out there, which ones are going to work, which ones will deliver, which ones are less certain, and really, is this macro target actually achievable when you look at the individual ways in which people think it's going to happen? So over to you, Nick.
Thank you very much, John. Yes, we come on to this, as John said, that we've talked about the macroeconomic issues, and we now come on to talk about the microeconomic in terms of how exactly can some of these savings be made whilst also meeting the quality and productivity challenge. The NHS has provided 12 separate national work streams that are designed to help NHS staff successfully deliver these changes, 5 of which relate to the commissioning of care and 5 of which relate to the running and staffing of NHS provider organisations. There are also 2 enabler, what they're calling system enabler work streams, which are essentially around primary care commissioning and around the improved use of technology, which are supposed to underpin the other 10 work streams in that sense.